Hello everyone, welcome to another video. So in today's video we're going to be looking at a condition known as benign prostatic hyperplasia, and we're also going to be covering prostate cancer. So basically, benign prostatic hyperplasia, it is a non-cancerous enlargement of the prostate gland and is caused by an increase in the number of epithelial and stromal cells, especially in the transition zone. So the enlargement compresses the urethra and it leads to urinary outflow obstruction. So let's break it down. Let's try to understand what's going on in this condition. We'll look at the anatomy and the physiology of the prostate and what is affected in this condition. So the prostate gland, it is a walnut-sized exocrine gland and is found only in men. So it is located below the bladder and it surrounds the upper part of the urethra. So the tube that carries urine from the bladder out of the body, and the prostate is divided into 4 anatomical zones. So there's the peripheral zone, which is the outermost zone, which is usually the common site for prostate cancer, which we're also going to talk about. Then there's the central zone, so the peripheral zone, the central zone, the transition zone, and the anterior fibromuscular stoma. So the peripheral zone is the outermost zone and is the common site for prostate cancer. Then we have the central zone, which surrounds the ejaculatory ducts. Then the transition zone surrounds the urethra, and this transition zone is the main site of growth in benign prostatic hyperplasia. Then for the 4th zone, that is the anterior fibromuscular stoma, there's non-glandular tissue, is a non-glandular tissue. So the prostate's main function is to produce seminal fluid, which nourishes and protects the sperm. So it secretes a slightly alkaline fluid that makes up about 30% of the semen volume. So basically, this benign prostate hyperplasia is non-cancerous and is caused by the enlargement of the prostate gland. So looking at the cause of this benign prostatic hyperplasia, so number 1, we have hormonal imbalance. So as men they age, the level of the testosterone in the bloodstream generally decreases. So the enzyme 5-alpha reductase converts the testosterone to dihydrotestosterone, that is DHT, which binds to androgen receptors in the prostate cells. So dihydrotestosterone is a more potent androgen that stimulates the cell proliferation in the prostate. Then another cause is aging. So prostate enlargement is rare before the age of 40 years, but it becomes increasingly common with age. So by the age of 60, there's up to like 50% of men experiencing symptoms of benign prostatic hyperplasia. Then genetic factors to like having a family history of early onset of benign prostatic hyperplasia increases the risk. Then inflammatory and growth factors too can be a cause. Like chronic inflammation may promote fibrosis and glandular hyperplasia. Then growth factors like fibroblast growth factor and insulin-like growth factor, they also play a role. So looking at the pathophysiology, the prostate enlarges due to hormonal effects of dihydrotestosterone, which stimulates the proliferation of both the glandular epithelial cells and the stromal smooth muscle cells. So in this majorly occurs in the transition zone. So like I said before, there are 4 zones. So it occurs in the transition zone of the prostate. So the dihydrotestosterone is what causes the enlargement, and then as the prostate grows, there is what usually occurs is number one, mechanical obstruction. So the enlarged gland compresses the urethra because it surrounds is the gland. This gland surrounds the urethra. So when it enlarges, it compresses the urethra, and this then further leads to like narrow urinary passage, and it usually makes urination difficult. Then number 2, there is dynamic obstruction. So there is increased smooth muscle tone in the prostate and in the bladder neck, driven by sympathetic nervous stimulation, and this adds further resistance to urine flow. Then also bladder response too. So the bladder compensates for this blockage, for this obstruction. It compensates by increasing the strength and the frequency of the destrusor muscle contractions. So over time, this leads to bladder wall hypertrophy, detrusor instability, and eventually urinary retention and residual urine, and also having recurrent infections. So what signs do we see when somebody has this benign prostatic hyperplasia? So the symptoms are classified. So we have, number 1, we have voiding symptoms. That is symptoms that we see due to the obstruction. So due to these symptoms, we see when the patient cannot easily pass out urine due to this blockage. So there will be difficulty starting urination, like hesitancy. Then there will be weak or interrupted urine stream. Then there will be straining during urination, like urination will be very hard for the patient. Then feeling of incomplete bladder emptying, like you just gone to the toilet, you just use the toilet, and you just feel like you did not really empty your bladder well, like there's something still holding some urine is still left behind. So there will also be prolonged urination time, because due to the obstruction, the urine cannot flow through the normal passageways, so it will take longer than normal for this urine to come out. Then these are for the voiding symptoms, so the symptoms that will occur due to the obstruction. Then we have another classification of symptoms known as storage symptoms that occur due to bladder overactivity. So there will be urgency to urinate, there will be frequent urination during the day, there will be nocturia, that is frequent urination at night, there will be urgent incontinence, that is involuntary leakage. Then looking at complications that can occur, so there could be acute urinary retention, that is the complete inability to pass urine. So this can be a complication that could occur in this condition. Then urinary tract infection, UTIs, are a major complication here, and bladder stones, hematuria, that is blood in the urine, and in advanced cases even kidney damage can occur. So let's look at the diagnosis of this benign prostate hyperplasia. So the first one is clinical evaluation. So the patient will have the history of their urinary symptoms, like not being able to pass urine, pain during urination, or like incomplete urination. So history of the urinary symptoms. Then digital rectal examination can be done to check for enlarged prostate. Then some laboratory tests can be done, like urinalysis, to check for infection in the urine or in the blood. Then serum creatinine to assess the kidney function, and then prostate specific antigen, that is PSA. It may be mildly elevated in cases of this benign prostatic hyperplasia. Then some imaging tests like ultrasound to evaluate the bladder and the prostate size, then measurement of post-void residual urine volume. Then for the another diagnosis we could do is something called uroflowmetry, and this is basically to assess the urine flow rate which is reduced when the patient has urinary obstruction. So for the treatment of this condition, looking at the lifestyle modifications, so we could advise the patient to reduce evening fluid intake, limit alcohol and caffeine, and we could advise bladder training and double voiding techniques. So for the medications that could be given in this case, we have alpha-1 adrenergic receptor blockers like tamsulosin and doxazosine. So the work of these alpha-1 adrenergic receptor blockers is that they relax the smooth muscle in the prostate and the bladder neck to improve the urine flow, and they could have some side effects like low blood pressure and dizziness. Then we also have another medication that could be used is 5-alpha reductase inhibitors. So for example, dutasteride, finasteride. So this group of drugs, they block the conversion of testosterone to dihydrotestosterone, reducing the prostate size. So this particular group of drugs, they target the hormones, so they prevent this conversion of testosterone to dihydrotestosterone, which is one of the major factors of the what causes the enlargement of the prostate. And removing this, stopping this conversion leads to the reduction of the prostate size. So this particular group of drugs, they also have their own side effects, because every drug has a side effect. So these ones, they can cause erectile dysfunction and also breast tenderness. Then we could do combination therapy too, but combination therapy is usually done when the prostate is significantly enlarged and the person is having very severe symptoms. Then another group of drugs that we could give in this case is the phosphodiesterase 5 inhibitors like tadalafil, and tadalafil also helps with erectile dysfunction. Then surgical treatments in complicated cases, we have transurethral resection of the prostate, which is the gold standard, and it basically removes the removal of the inner part of the prostate. Then laser surgery, and here is using lasers to vaporize or inoculate the prostate tissue. Then open prostatectomy is done for very large prostates that are not manageable with that are not manageable endoscopically. So the prognosis of this condition, so benign condition is basically non-cancerous, but it can cause significant morbidity if untreated. Then most men, they respond well to treatment, and long-term monitoring of this condition is usually very important. So that is all for benign prostate hyperplasia. So now we're going to talk briefly about prostate cancer. So prostate cancer is different from benign prostate hyperplasia. Is like the malignant form of this condition, if I'm to put it like that. So it's a malignant neoplasm that arises from glandular epithelial cells of the prostate, most commonly known as adenocarcinoma. So it typically originates in the peripheral zone, like I explained before, in the transition, the different zones in the prostate. So the transition zone is where this benign prostatic hyperplasia most commonly affects. Then prostate cancer is in the peripheral zone, so it typically originates in the peripheral zone of the prostate, and it may remain asymptomatic for years before progressing. So looking at the etiology, so for the etiology or the causes, number one, age. The incidence of prostate cancer increases with age, with the peak being men that are greater than the age of 65 years. Then we also have race. So prostate cancer is higher in black men compared to the whites, and is more aggressive in black men. Then we have genetic disposition too, so certain genetic mutations, and having first degree relatives with history of prostate cancer. Then hormonal influence too, so androgens generally promote the growth and the progression of this cancer. Then environmental and lifestyle factors, like having a high fat diet, being obese, smoking, having a sedentary lifestyle. So these are just basically what could lead to this condition. So looking at the pathophysiology, there is malignant transformation. So the glandular epithelium transforms under hormonal stimuli. So there will be tumor growth. So the tumor growth will originate in the peripheral zone, and it may extend to seminal vessels, the bladder, or the rectum. Then metastasis. So there will be lymphatic spread, and then there will be hematogenous spread. So the lymphatic spread will be in the pelvic and the para-aortic nodes. Then the hematogenous spread will be predominantly be to the bone. So looking at the clinical features, so prostate cancer is often asymptomatic in the early stages, and urinary symptoms are similar to benign prostatic hyperplasia. So there will be difficulty urinating, incomplete urination. So it's basically the same urinary symptoms we see in benign prostate hyperplasia, we'll see it in prostate cancer. Even the urgency to urinate, all those bladder overactivity will be there. And then there will also be hematuria or hematospermia, so presence of blood in the urine or sperm in the blood in the urine. Then there will be bone pain, especially in the lower back, in the hips. And then there will be weight loss. There will be weight loss, fatigue, and anemia in advanced cases, and also spinal cord compression in the late stages of metastasis. So looking at the diagnosis, so one of the diagnoses is digital rectal exam. So digital rectal exam can show presence of irregular prostate or hard prostate. And then there's also another diagnosis known as transrectal ultrasound guided biopsy, which is a definitive diagnosis for this prostate cancer. And then some multiparametric MRIs for staging and biopsy targeting. Then looking at the treatment, so number one, active, like just having active surveillance of the patient for localized and low risk cases. Then there's something called radical prostatectomy, which is the complete removal of the prostate and the seminal vessels. So this is like a surgical treatment, and the risk is that it can lead to erectile dysfunction. Then there's also radiotherapy, so external beam radiation and Then for hormonal therapy, that is when we're trying to use this to mean that we're going to do androgen deprivation for the hormonal therapy, because is increasing the androgens that lead to the growth and progression of this condition. So we can use luteinizing hormone releasing hormone agonists like luprolide. Then we can use antiandrogens like bicalutamide. Then so this is what we can use, and the goal is to reduce the testosterone levels. And then chemotherapy too can be done for metastatic or hormone refractory cancer. So when we're doing chemotherapy, the first line is prednisone plus docetaxel, and another treatment option is bone protection. So we could give some medications for bone protection too in cases of bone metastasis. So looking at the prognosis of prostate cancer, so when there's localized disease, that is when we have low risk prostate cancer, there's excellent survival of this condition, about greater than 90%. There's a chance of like up to 10 years survival. But in advanced diseases, it's treatable but it's not curable, and survival rates varies. So that's basically the breakdown of these two conditions known as benign prostate hyperplasia and prostate cancer. So I'll see you in the next video. Thank you.